Good morning, everyone, or good afternoon, depending on what time you watch this. This is my video submission for the Dr. Clifton K. Meter video session. So let's get started. My poster is on understanding how communication dynamics between allied health professionals and metastatic cancer patients can increase the use of advanced care planning. I conducted this research this past summer at Stanford University. I am a current second-year student at Meharry Medical College in the School of Medicine. So hello, everyone. My name is Nia Chanel Boles, and I'm excited to give you my presentation. So the purpose and objective of this project was to really understand more about communication between allied health professionals and metastatic cancer patients who engage in advanced care planning conversations. And what we've seen from previous studies is that engaging in advanced care planning conversations with patients, especially those who may have a shorter life expectancy due to old age or disease prognosis, is an efficient and compassionate way to make sure that patients feel supported during their final stages of life. So various institutions have actually begun to implement the use of allied health professionals to carry out these advanced care planning conversations, because oftentimes physicians feel as though they are too overburdened or they don't have enough time to engage in these conversations with patients. Trained allied health professionals can help patients navigate their illness and develop a care plan that really aligns with their treatment goals. And what studies have shown is that patients who complete advanced care planning discussions had significantly lower hospitalization rates and trends towards lower chemotherapy use, fewer ICU visits, and fewer ER visits in their final 30 days of life. So the goal of this study was to examine what, if any, factors could impact the response rate of metastatic cancer patients who were contacted by allied health professionals to discuss advanced care planning. We hypothesized that by evaluating the methods of these allied health professionals, we will better be able to determine what, if any, strategies can help improve response rate amongst patients. So for our response rate analysis, we retrospectively reviewed the demographics of patients who were contacted to engage in advanced care planning conversations. We examined trends between race, age, and the experience level of allied health professionals to determine if either of these factors influence the response rate of metastatic cancer patients. Patients were reviewed from several clinics within the Stanford Medicine Cancer Center, and in subsequent studies, we're also going to be examining the zip codes of patients to reveal any social economic factors influencing response rate. We then took all of this data and performed a multivariable logistic regression to determine the response rate odds ratio for patients in different demographic groups. So if you move to the center of the presentation, this is like the meat and potatoes of the poster. You see on this side is the different categories. So first you'll see the patients were separated by cancer clinic at Stanford Medicine. Each cancer type has their own clinic. And then you can see here the overall number of patients for each demographic. And we had an N of 871 patients. And then this column here is the percentage or number of patients who responded to the allied health professionals. And what we counted as responded and began to fill out the advanced care planning form. There is a smart form that Stanford Medicine uses. So that is what we considered responded. And then we calculated the odds ratio and p-value for those demographics. So starting at the top with the cancer clinic, this was a surprising result for us because we did not expect to see differences between the clinics. But what we saw was that the thoracic and the CCSB clinics had a significantly higher response rate amongst patients. And we later attributed this to the fact that some physicians are more receptive and encouraging of the allied health professionals. They tell their patients, expect a call, expect someone to contact you to have this conversation. They're supportive, they're engaged, whereas some physicians may not be as supportive. And we've even known of a few physicians who have told the allied health professionals not to contact their patients. So this is what we attributed those differences to. But if we move down, this is a very interesting result that we see here, because we use predicted to survival in months, and we contacted patients who had a survival who had a predicted survival of less than 2 years. So we further categorized that into months. So 0 to 6 months, 6 to 12 months, and then 12 to 24 months. And what we see here is a nice downward trend where the patients in the 0 to 6 month survival group had a higher response rate compared to patients in the 12 to 24 month survival group. And this was something that was expected. You know, if you're a patient and a physician tells you, you know, unfortunately, I'm very sorry, you only have 6 months to live, you may feel a little bit more adamant about having the advanced care planning conversation, because that way your needs will be met and you feel comfortable and you're just better able to understand your disease prognosis. So as we move down, this was where things started to get a little surprising, because we saw that male patients were more likely to respond, with 56% of male patients responding compared to only 44% of patients, of female patients responding. So this was actually very surprising to us, because most of the literature says the opposite. Most of the literature says that male patients are less likely to respond or be engaged and receptive when it comes to their healthcare. So this was something that really surprised us. Moving down as we get into race, another thing that completely shocked us was that Black patients were significantly more likely to respond, with 75% of the contacted Black patients responding. This was huge for us because, like previous studies about male and female patients, it's been shown that Black patients are less likely to respond, and this is for various reasons: healthcare disparities, socioeconomic barriers, barriers to care in general. So this was a statistic that really surprised us. Moving down, we don't really observe any surprising differences with ethnicity. Something to note is that Hispanic patients were less likely, out of the 3 ethnic groups, well, Hispanic, non-Hispanic, and unknown, were less likely to respond. And this could be due to the fact that there are often language barriers. Many Hispanic patients are only Spanish speaking, whereas providers are not always, do not always speak Spanish. So having an interpreter or having to use family members to interpret could be a barrier to care that we should look at a little bit more. And we didn't really see any differences between age as well. So just to sum up the results, we observed several trends that impacted the patient response rate, including which care clinic they were treated at, sex, and race. So we saw that race played a significant role in which patients responded, with Black patients reporting a higher response rate. And response rate was also impacted by which cancer clinic the patients were seen in, with the thoracic and CCSB clinics reporting patients with significantly better response rate. So to conclude, we hope to use all of this data and information to determine how differences amongst patient response rate could be mitigated to help improve the overall response rate of patients within the cancer center. And for future directions, we actually have a second component of this study, which will be a qualitative analysis. And in the next phase, we will be interviewing the allied health professionals, because we hope to gather demographic information to determine if this may play a role in the patient response rate. We hypothesize that race-matched allied health professionals, so for example, an Asian allied health professional reaching out to an Asian patient, we hypothesize that there will be a higher response rate, because patients feel more comfortable when they are seen by a provider that identifies as their same race or ethnic group. So this is the next phase of the study that we are very, very excited about. So for acknowledgements, a huge thank you and shout out to Dr. Michael Gensheimer. He is a radiation oncologist in the Stanford Medicine Cancer Center, who works primarily on head and neck cancers, but he was my mentor this summer, and I had a great experience working alongside him. So he was a huge supporter. So thank you to him, and thank you to the entire Stanford Radiation Oncology Department for their support. And lastly, but of course not least, thank you to the Stanford and Meharry Reach program for providing funding and resources for the entire summer. And I'm going to move my icon up here so that you can see the resources that I use for my study, a lot of literature review. So thank you so much for your time, and I hope you all enjoyed my presentation. Thank you.